This is Nizar Mullani. I'm a retired associate professor, University of Texas Medical School. I'm a founding partner of 3Gen. I'm owner of Translight LLC, which makes the vein light device. Conflict of interest. I'm a physicist who has spent 50 years designing medical equipment in the area of positron emission tomography, created the derm light and partnered in 3Gen, and created the vein light and the owner of Translight LLC. Some of these slides and material in this presentation are borrowed from Drs. Cabo, Brown, Margub, Dawan, Duvik, Rabinovitz, et al. The presentation is dedicated to my life partner of 52 years, Linda Mullani, who was detected with melanoma 30 years ago and was operated on by Dr. Bulge. She lived melanoma-free until her bout with esophageal cancer this year. But she basically let me become aware of melanoma, and that basically melanoma, when it's detected early, can be excised and the patient can be cured. But if detected late, it can be pretty deadly. So here's an example of what melanoma does with PET scans taken 28 days apart, 2 sets of PET scans taken 28 days apart. In this patient that was being studied with an anti-angiogenic medicine protocol. On the left-hand side is the 28-day image, and on the right-hand side you can see that the number of lesions, the metastatic melanoma lesions, have almost doubled. So if you look in this area, you can see the large number of melanoma lesions. Also in the stomach area, you can see a tremendous growth. And this basically is a good example of what happens with metastatic melanoma and you know why the chances of survival are pretty low. In the bottom right section is an image that's also one of the unique images. On the right-hand side on the left-hand side is the melanoma image with metabolism like FDG, and you're seeing these 2 melanoma lesions plus this one here glow pretty high with uptake of glucose in the melanomas. And on the right-hand side, you see that the blood flow is also increased in melanomas, and indicating this is also a high blood flow over here. So both blood flow and metabolism are increased in melanomas at a high rate. On the top left, you will see an attempt at trying to do this imaging to see if we can localize an area of increased blood volume around the pigmented area of the melanoma. So here's a classic image taken with oil, ELM, and epiluminescence, and you can see that the outline is drawn here. And on the right-hand side is a picture taken with transillumination ELM. This is done with a nevoscope device, and you can see a larger area of the tumor that is actually involved in the growth of the melanoma. Now, polarized light versus contact dermoscopy. There's some questions asked about this all the time. Which one is better? My personal feeling is I think you have to use both of them. So when I first designed the prototype, the polarized light derm light, it was in 2000, and I showed it to some of the dermatologists that were visiting at the AAD meeting in 2001. And the origin, I'm sorry, in 2001 is when we introduced the original DermLight DL100 using the 3-gen DermLight device. Once the advantages and disadvantages of polarized light versus liquid contact dermatoscopy are really important, and I will enhance this with a few slides a little later. Now, contact imaging with glass faceplate compresses the tissue and blanches the blood from underneath the glass faceplate. This causes a blanching of the blood totally from the lesion. And one of the nice things about this is once this occurs, you can actually see deeper into the tissue and not be obscured by the blood volume. Here's an example of what happens when you use non-contact cross-polarized light. You can see a large area of the BCC involved in this. High blood volume, which is characteristic of blood of BCC. And on the right-hand side, you can see that the cross-polarized blanches out if you have contact. So all the tissue, you only see a few blood vessels here and there, but that's about it. In the non-contact imaging, the non-contact imaging with polarized light is fast and easy to use. So it's great for using for screening patients. If you see 8 to 10 patients a day or more, and you have to screen them for the whole body or something for looking for skin cancer, the fastest way to screen and to triage the patient is to use polarized light, which does not require any contact or any oil or anything. Now, non-contact imaging provides information on blood volume in a BCC or SCC or dermatofibroma. Using both mode enhances the skin cancer detection. And here's an example of a dermatofibroma, which is highly vascular. On the left-hand side, it has a contact image, and you can see that the blood is pushed out, and I can see the structures within the white areas better. You can also see some of the structures here much better with the pigmentation. With the non-contact, you can see that the blood volume, it really is enhanced, is filled with blood, and it's difficult to sometimes see some of the features. So I will skip this. This is simple. Imaging skin cancer with light. Now, this is a part of the issue that has been very special to me. When you use light, the electromagnetic spectrum is basically spread out from 400 to 700 nanometers. At the end of the visible spectrum, we have the UV, and on the other end, we have the infrared frequencies, which we cannot see. However, these frequencies play a big role in skin cancer detection. So here is the spectrum that we are actually able to see, which is a narrow band of about 300 nanometers at the most. But we call this white light because when we combine all these lights together into what is seemed to be like a sunlight mixture, we call that white light. But in essence, what is white light? That is a very big question, because when we see things at nighttime, all the light basically shifts to one end or the other, because as the light dims from the sun, everything becomes a little bit more red and a little bit more orange. So sunlight changes throughout the day. Trying to get white light to be this, a standard is very, very difficult. So for example, in the old days, we used to use the old light bulbs, incandescent light bulbs, and those were at 3900 Kelvin. And today, if you put that same light bulb next to an LED-based light bulb, you'll see that it's from 6,000 to 12,000 Kelvin, which is a very bluish white color. Does the color of light help detect skin cancer? Yes. And in the devices that basically I've been involved in designing, we always select the colors to enhance the blood vessels and pigmentation. These are the two most important features that are characteristic of malignancy in pigmented lesions. It's an example of the spectrum, absorption spectrum for light from 400 to 700 nanometers. And basically what you'll see is the hemoglobin, the deoxygenated hemoglobin is highly absorbed from 600 nanometers to about 700 nanometers. Beyond that, we're not capable of seeing these frequencies. But before that, around the 400 and 560 nanometer is another peak of absorption caused by the oxygenated blood also. So having this piece of information, we can tailor the detection of blood vessels by using the different features. Now, melanin has an exponential decay of absorption. So from 400 to 700 nanometers, you will see that the melanin starts to decay. And it's not as strong absorption from 600 to 700 nanometers, but certainly very strong from 400 to 500 nanometers. Now, is there a difference between polarized and non-polarized dermoscopy? Yes. One of the main reasons why there is a difference is because the polarized light has to go through the lens into the tissue, and it's only after it rotates its polarization that it becomes depolarized enough to reflect back into the tissue. So about the 100 to 150 microns of tissue is where there is very little feedback coming back from the polarized images. But once it gets into the tissue, then it basically becomes a much stronger signal coming back than if you use a non-polarized dermoscopy. In a non-polarized dermoscopy system, the liquid interface produces a really good area for the light to penetrate. But as the light penetrates deeper, it also becomes less sensitive. And so these deeper areas are not as well imaged as the superficial image in the non-polarized image. Now here's an example of what you see if you use polarization in the parallel and cross-polarization mode. Parallel is basically in line with the two polarizers are aligned, so that what you see is just the surface of the lesion, and only the surface part, which was actually missing before, it is reflected back into the system. The cross-polarized shows you the deeper areas of blood, and you can see the blood vessels that are deeper. Now, what happens if we were to rotate the polarization? If we start off, and this was taken with a platinum device that we had, which allowed you to rotate the polarizer in the front. By setting the polarizer at 0 degrees, you're allowing the parallel lights to come through. So you can see all the indentations from the skin kind of show up. As you rotate it to 30 degrees, you can see now that the indentations are not as strong, and you're starting to see a background over here, which may be the tissue that's damaged. And at 60 degrees, you see a large area which is damaged, but you still see some inundation. And then when you get to 90 degrees, you see the deeper areas of the sun damaged area. So it's possible then to actually do depth imaging using the device by rotating the polarizer. Now, yellow, orange, and red lights penetrate deeper into the tissue, more so than blue or green light. Orange light can be used to view deep pigmentation, and still the melanin absorption is pretty high. So in the DL3 and DL4, we have what's called Pigment Boost. And does the Pigment Boost work? Here's an example of how this device basically makes use of the fact that there's high transmission of the orange light. By using the orange light to do the Pigment Boost, we still maintain the absorption in the hemoglobin. So, and also in the pigment. Here is an example of white contact non-polarized image, and you can see that the superficial areas are seen quite well. But if you look at the contact polarization, you see that basically polarized light goes deeper, as I indicated before. You can see the deeper structures a little bit better. By adding the orange light to it, you can actually enhance the visualization of the pigment area in the lesion. Now, one of the things that has been an issue with polarized light or with the contact dermoscopy is how do you image things that cannot have a contact glass faceplate. So this is a Dermlight GL, which has a longer eye relief. And you can actually visualize all the different blood vessels very clearly in the eye. Or you can actually see underneath the tongue. You can see the vascularity underneath the tongue. Or you can see deep inside the throat and look for oral cancer. And these devices allowing you to use for oral cancer detection could be a major boon to some of the East Asian countries that actually have a higher incidence of oral cancer. One other thing is the fluorescence imaging of BCC, and this feature has been added on to the Lumia 2 device. This is a color filter that basically blocks out the 405 nanometer signal. And if you're using ALA, which fluoresces red, then you will block out the blue part of it, and then you will see the red fluorescence image. So here's an example how the blue is for most part blocked out, and I can see the fluorescence in the BCC. Here's another example of what you can do with UV light. Here's just, oops. Here is an image of a person, a volunteer. You can see the UV light enhances all the oil glands over here. You can see the sun damage areas pretty clearly. So it's quite possible to enhance the visualization of sun damage in other areas by using ultraviolet rays, which are not visible to us, but we can actually observe the fluorescence from the ultraviolet rays that impact the tissue. So what's in the future for dermoscopy? I believe that the artificial intelligence-based dermatoscopes that can image and diagnose skin cancer more accurately than the average physician will be the way to go in the future. Use of dermatoscopes by GP and FP family practitioners to screen for skin cancer early using the AI-enabled dermatoscopes will radically improve or increase the detection of skin cancer early. And with that, we hope that we can actually solve the problems with skin cancer and eliminate it, hopefully, in the future. So thank you very much. Thank you for listening to my talk. And I will be there on Wednesday to answer any calls. Thank you.